Chest trauma and thoracic injuries. Thoracic injuries are the causes of death in 20% to 25% of all trauma victims. Injury to the chest wall is found in 45% of these thoracic trauma victims. Traumatic injuries fall into two major categories: blunt trauma and penetrating trauma. Blunt trauma occurs when the body is struck by a blunt object, such as a steering wheel. The type of force involved in blunt chest trauma injuries include deceleration, acceleration, shearing, and compression. The external injury may appears minor, but the impact may cause severe, life-threatening internal injuries such as a ruptured spleen. Contractile trauma is a type of blunt trauma. It is caused by the impact of a part of the body against other object. This type of injury differs from blunt trauma partially in the velocity of the impact. Internal organs are rapidly forced back and forth within the bony structure that surrounded them, so that internal injury is sustained not only on the side of the body impacted but also on the opposite side where the organ or organs hit bony structures. If the velocity of impact is greater enough, organs and blood vessels can literally to thrown from their point of origin. This is the shearing injury that can cause transection of aorta, hemothorax, diaphragmatic rupture injuries. Compression injury occurs when the body cannot handle the degree of external pressure during blunt trauma, resulting in contusions, crush injuries, and organ rupture. Penetrating trauma occurs when a foreign body impales or passes through the body tissue. Example: gunshot wound, stabbings. Thoracic injury range from simple rib fracture to life-threatening tear of the aorta, vena cava, and other major vessels. The most common thoracic emergencies and their management we will discuss. Firstly, we discussed about common traumatic chest injuries and mechanisms of injury. Mechanisms of injury: blunt trauma, blunt shearing wheel injury to chest. Common related injuries are rib fracture, flail chest, pneumothorax, hemopneumothorax, myocardial contusion, pulmonary contusion, cardiac tamponade, great vessel tear. Next, shoulder ham seatbelt injury. That is common related injuries are fractured clavicle, dislocated shoulder, rib fractures, pulmonary contusion, cardiac tamponade. Crush injury, management of thoracic injuries. Already we will discuss in previous videos pneumothorax, hemothorax, and tension pneumothorax in detail. Next we will discuss flail chest. That means fracture to two or more adjacent rib in two or more places with a loss of chest wall stability. The clinical manifestations are paradoxic movement of chest wall, respiratory distress associated hemothorax, pneumothorax, pulmonary contusion. The emergency management of flail chest: stabilize flail segment with intubation in some patients, tapping in others, oxygen therapy, treat associated injuries, analgesia. Flail chest results from multiple rib fracture causing an unstable chest wall. The diagnosis of flail chest is made on the basis of fracture of two or more ribs in two or more separate locations causes an unstable segment. The flail segment usually involve anterior or lateral rib fracture. The chest wall cannot provide the bony structure necessary to maintain blouse action and ventilation. The affected area will move paradoxically with respect to the intact portion of the chest during respiration. During inspiration, the affected portion is sucked in, and during expiration, it bulges out. This paradoxical chest movement prevents adequate ventilation of the lung in the injured area and increase the work of the breathing. The underlying lung may have a pulmonary condition aggravating hypoxemia. The associated pain, fracture, and lung injury give rise to an alternation in breathing pattern and hypoxemia. A flail chest is usually apparent on visual examination of Unconscious patient. The patient manifests rapid shallow respiration and tachycardia. A flail chest may not be initially apparent in the conscious patient as a result of splitting of the chest wall. The patient moves air poorly and movement of the thorax is asymmetric and uncoordinated. Palpation of abnormal respiratory movement, evaluation for cryptus near the rib fracture, chest X-ray, and ABGs all assist in the diagnosis. Initial therapy consider of airway management, adequate ventilation, supplemental oxygen therapy, careful administration of IV solutions, and pain control. The definite therapy is to re-expand the lung and ensure adequate oxygenation. Although many patients can be managed without the use of mechanical ventilation, a short period of intubation and ventilation may be necessary until the diagnosis of the lung injury is complete. The lung parenchyma and fractured rib will heal with time. Some patients continue to experience intercostal pain after the flail chest has resolved. Cardiac tamponade. Blood rapidly collects in pericardial sac, compress myocardium because the pericardium does not stretch and prevent heart from pumping effectively. Clinical manifestation of cardiac tamponade is muffled, distant heart sound, hypotension, neck vein distension, increased central venous pressure. Emergency management, medical emergency, that is pericardiocentesis with a surgical repair as appropriate. We will discuss cardiac tamponade in next videos. So thank you for listening.